Thank you for joining and welcome to today's webinar. Today's webinar will take place during the European Public Health Week. And today the topic is healthy aging versus multi-morbidities in a digital world. And our webinar really focuses on how to implement integrated care. So much more the how than exactly the what. My name is Ewout van Ginneken, and I'm moderating today together with my colleague Erica Richardson. Erica will be taking care of the chat box, so please put all your questions there and we will get back to those later. The incidence of multiple chronic disease is rising, and that has significant societal but also economic implications. People with multimorbidity have a lower quality of life, higher healthcare utilization, and health inequalities are also much larger. They have lower productivity, but still, our systems are very much focused on single diseases. And what we therefore need is a system that is much more holistic in its approach, much more person-centered in its approach, and also one that integrates between social care and healthcare. Today, we will focus on how to overcome these barriers to integrated care, which are created by separate funding schemes, separate regulations, separate delivery systems between social care, healthcare. And we will also launch a brief about the same topic today. And we will do this with the following speakers. The first one is Dr. Verena Struckmann, who is a senior research fellow who is focused on integrated care and global health. And she's from the Berlin University of Technology and also affiliated with the Berlin Hub of the European Observatory. And she will give us a keynote presentation focusing on the strategies to implement integrated care. Then we will have 3 spotlights. And the first one will be Professor Mieke Rijken from Nivel in the Netherlands and also the University of Eastern Finland, who in her work also focuses on person-centered care. And she will talk about evaluation models and the role of research in this. And then we will hear from Dr. Helmut Hildebrand. I think we had some trouble connecting him. I hope he can make it, otherwise we will just move to the next. He is the chairman of Optimedis, which is known for several population management models, most notably probably the Kinzigtaal model. And he promised us to tell us about what he sees as the main lever to pull to integrate care and implement integrated care. Then, as a final speaker, we will have Professor Søren Kristensen from the Danish Center for Health Economics. And he has lots of experience studying integrated care models and especially also its financing. And today he will be focusing on payment models and the role of incentives. But without much further ado, I would now like to move over to Verena for the keynote. Verena, the floor is yours.
We will dive a bit deeper into the topic of how to implement integrated care, and I will show you some of the lessons we have learned during the last years across several different EU countries. First of all, I will start with a short definition of integrated care in order to set the scene and to have a basis of what we're talking about. And then I will give some background information of where we have derived the information from. And then I will introduce you to some selected strategies on how to implement and scale up integrated care. If we talk about integrated care, it's quite important to define what we're exactly talking about, since there's a plethora of terms and different terms are used for the same meaning. Some people would say it's coordinated care or managed care, etc. For our brief, we have chosen to use a definition we have developed in one of our EU research projects, which defines integrated care as the structured effort to provide coordinated, proactive, person-centered, multidisciplinary care by at least 2 or more communicating and collaborating care providers, which may work at the same organization or also at different organizations or institutions within either the social health care or community care sector, which also includes informal care. And how have we come up with these strategies? I want to introduce to you now. So first of all, there has been one EU research project, which was called the I Care for You project, where we initially identified over 100 programs across 25 different European countries. It was a mapping initiative and kind of a starting point where we started to identify what is delivered in terms of integrated care across different EU countries. And to back this up afterwards, we also conducted the SELFIE research project, where we selected 16 integrated care projects according to different domains in 8 EU countries. According to certain criteria we set up beforehand, and we investigated these projects more into detail and evaluated all of them. And as a result, also as a result of the I Care For You project, the SELFIE research project, and of a very thorough literature review, we came up with the policy brief you've already seen on the first slide. And as I've already said, we have developed 12 overall strategies, but due to time constraints, I will focus on a selection of them today, and I will introduce 6 strategies out of the 12. However, all of them are of relevance in terms to overcome barriers to an integrated care provision. Because all of these barriers, as Evert already mentioned, are created by, for example, separate funding or regulation or delivery systems which are not the same for health and social care. Let's have a look at the first strategy, which is really important and easy said, but not easily implemented. And this is really the basis for every integrated care project, or let me say every effective and sustainable integrated care project, is to apply a collaborative governance in terms of sharing the same narrative and the same vision from the beginning on, which means everybody, every stakeholder who is involved in this integrated care project needs to be involved since the startup of the project, with continuous communication, with continuous meetings to achieve consensus on what we as a project team want to achieve together with this integrated care project. And we've seen this across several projects. Now I've chosen one from Austria, which is the Health Network Tennengau, which involved all major players from health and social care in their project from the beginning on. Because this was the only way to gain trust and to develop mutual trust, which is the basis for the program and for many other programs as well. They were meeting frequently in some formal ways, but also in an informal manner. And this was a major reason why they developed to be a model region here. And if we look at the next strategy, which is from the overall 12 strategies, it is our strategy 4, which is to create feedback loops and continuous monitoring, where some might think, well, this is pretty obvious that this is needed. However, this is not always implemented, although it's necessary not only during the implementation phase, but already during the planning phase, where all stakeholders need to be involved to provide feedback for improvement and for adaptation, and also across all the professionals who are involved in this integrated care project, in order to see where there is room for improvement, in order to increase, again, the trust issue in terms of everybody is sharing insights, and there's not a competitive environment, but instead an environment which leads to continuous growth together in order to improve the quality of care outcomes in the end, and to have robust evidence to work on. And there were different projects which included different ways of monitoring. And for example, the Care Chain for Elderly project from the UK was one where also the patients were included during these feedback loops, since those are the ones receiving the care. I'm now moving to strategy 5, which focuses on securing long-term funding and the adoption of innovative payment that overcome fragmentation. And as you can see, we have also written a policy brief on this topic a couple of years ago, and we have further identified additional literature, of course, during the last years, which we have included in our current brief. And many projects have taken advantage of some startup funding. However, this is not enough in order to sustain the project in the long run. And here we have identified that it is very important to apply collaborative governance, especially with payers, and to develop models which really incentivize integration. And there are different opportunities here. Some projects applied, for example, a shared savings approach, which was applied across and delivered by players from different sectors, and they agreed upon sharing the savings if, for example, health outcomes improved. And Søren will also go a bit more into detail with respect to this strategy later on. Another important aspect which came up also from the literature and also from several interviews we conducted is the case that all these different projects, of course, include professionals from very different disciplines. And the idea is to start with the education, to start with interprofessional education as early as possible in terms of involving professionals in same classes, maybe on the same campus, to start from really from the onset of the education to speak, so to say, the same language in terms of terminology, to lower the hurdles in terms of collaboration, and to understand the importance of each other's roles, skills, and responsibilities in order to acknowledge each other during the care process. And here we have an example from the Netherlands, which launched the medical specialists program. And there was a strong emphasis on interprofessional collaboration, patient safety, and things like shared decision-making, which are inevitable in integrated care. And for example, also the substitution of certain roles with new professional roles in order to increase efficiency and to improve role flexibility from all those involved. And now I'm moving to strategy number 9, which is focusing on different ICTs, since ICTs can ideally support the collaboration and the communication and also the exchange of information in integrated care outcomes, if implemented in a way that interoperability of systems is assured. And this is something which usually is not available very often from the onset, since it must be discussed among the group of stakeholders involved, which information and which data do we actually really need, what is required in order to be exchanged in order to improve care outcomes, patient outcomes. And here we have an example from Spain, where the electronic health record, which was implemented in this program, was combined with the Catalan shared medical record, which improved, of course, the monitoring process and the exchange of relevant patient information. And during this entire process, IT professionals and the end users itself were involved, and was a gradual implementation and development process over several years until they came up with their final solution here. And to move to the final strategy already, this is the flying wheel of all the strategies. Since we have identified 12 strategies, which are ideally combined and not solely implemented just to pick out strategy 2, 7, and 9. I've just done this now to showcase some of the strategies a bit more into detail. However, all of them are of importance and relevance to keep the integrated care project running, as the alignment of the components also at the different levels, the level of the patient, the level of the care provider, and also in the macro environment where we find the policies, is very important, since one is not running well without the alignment of the other. And simultaneous action at all different levels is really a prerequisite for an effective integrated care program in the end, which can also be seen with individualized care plans if they are implemented solely focusing on certain aspects. They will not end up with the most efficient results. A holistic picture and holistic assignment of all aspects need to be included here. And this already leaves me with some concluding remarks and thoughts. So it's always necessary to acknowledge the different context we're implementing an integrated care program, since of course this differs, and thus there is no blueprint which we can apply. It needs to be context sensitive, and ideally it is built upon already existing structures and projects, which ensure that projects also develop with a bottom-up strategy and ensure commitment at all different levels. And of course, if you think globally and use existing frameworks or evidence, as we have done here, these still needs to be adapted to the local context where we're implementing an integrated care program, in order to have a context sensitive program, which is also adapted to the target group, which might differ with their respective needs. And ideally, policymakers should foster a supportive macro level environment. For example, as I've mentioned before, with respect to securing long-term funding to secure the sustainability of projects, and that we do not end up with several pilot projects which are not running anymore, even though evidence shows that they have been successful. And the role of evidence is, of course, very important, as highlighted with the monitoring part already, that we need thorough evidence from different levels in order to verify the success of a project. But Mika will also go more into detail to this topic. And finally, it is also a post-pandemic opportunity to adapt care delivery in a more integrated manner, since, as Ewout acknowledged, the incidence of multiple chronic conditions is still rising, and the delivery of cohesive and integrated care depends on the strategies I've just mentioned, and also gives room for improvement, maybe also on the basis of what we have learned and experienced during, for example, COVID-19 in particular. Thank you very much for your attention, and I hand over to Ewout again.
Thank you very, very much, Verena, for this presentation. I think it really lays out the issues very well. I think it's so important to start this conversation again, really, on how we can support, treating, and the models for people with multimorbidity much better than we currently do. There are so many different initiatives currently that are really focused, as either on single conditions or cancer or CVD, but we also an integration in these areas, but not bringing it together. So I think it's really important that we keep pushing and also show the kinds of strategies to follow that countries can use. So thank you for that. I would now like to go over to Mieke. So Mieke will talk a little bit about, you know, what we as researchers do and the way we evaluate these models and what is needed really, you know, from us and what we should do better perhaps, so to have the right evidence available. And please also post your questions if you have any for Verena or for Mieke or for anybody else. So Mieke, please switch on your camera. The floor is yours.
Thank you, Ewout. Yeah, first of all, I would like to say that I'm very happy with this new policy brief because of its focus on the implementation of integrated care models that do not have a disease-specific approach, but focus on person-centered care that better suit the needs of people with multimorbidity. Now, regarding their implementation, I'd like to say two things that are important to consider before starting to implement anything, actually, and these relate to the selection of the integrated care model or the interventions that you want to implement. I guess we're all familiar with the consolidated framework for implementation research, and one of the constructs of this framework, which is considered critical for successful implementation of innovations, is the evidence base underlying the innovation or the intervention. And I believe this is key because stakeholders, actors, they all need to be sure that they implement something that will work to meet their goals, and considering that they put a lot of effort in this implementation and that they may also often need to convince others who may need to make changes in their work processes or learn new skills or take new roles. And yeah, I'm aware that what I may say now, that not all of you may like it, but I believe that we should not take the evidence base for integrated care for granted. In particular, not for those new models of person-centered care. I don't talk about the single disease, chronic disease management programs that have been studied quite extensively. So, to my opinion, it's too early to state that there is already ample evidence for the effectiveness or cost-effectiveness of these new models. And so I'm pleased to read in the policy brief a plea for rigorous evaluations. And of course, this is not a task of implementers and stakeholders, but it's a task of researchers who should do this together with implementers and stakeholders. And as being a researcher myself, I believe that we as researchers should do a better job and that we need to conduct evaluation studies and also design evaluation studies that do justice to the complexity and the context dependency of integrated care and these new models in particular. And it means that RCTs may not always be the best choice as the design for these evaluation studies, that other designs, but also other outcome measures and methods may be needed or improved. And I believe this is really something that requires a strong collaboration between all of us. The second point I'd like to make that relates actually to what Verena just mentioned, the first strategy on developing a shared vision. And that is that I believe it's very important to understand that there is no integrated care model that will meet all expectations. So if a model has been designed to improve the health outcomes of a certain patient population, you cannot assume that it will also improve patient experiences or other outcomes. That may be, but you don't know this yet. So if you consider the principal aim, I believe it's crucial to have a clear and common understanding of what actors and stakeholders together aim to achieve with the implementation. And I'd like to illustrate this by some work that I've conducted in the Netherlands in 2 regions, where general practices wanted to implement a proactive person-centered care model for their patients with multimorbidity to improve the quality of care. And the model was it was very much like how it is written in the policy brief. So starting with the identification of the patient target population, and then further developing this, reaching out to these patients and so on. Now, when we showed the GPs how many of the patients had multimorbidity, they realized they had to confine the patient group and then answer the question, whom should we offer this type of care? And then it became clear from these discussions about the patient target population that actually the practices, but also staff and management within a practice and local partners had all different reasons why they wanted to implement this person-centered care model. For the sake of time, I will not go into detail, but what I'd like to say, my main message is that you first need to agree on what you aim to achieve and for whom, before you can decide what an appropriate care model would be to implement. And this sounds very self-evident, but it's not always the case. I've seen quite often that there is a good practice identified, and many are interested to transfer this to their own local context. And of course, I'm very happy with that because, as I said, I'm very much in favor of implementing something that has proven that it can deliver. But please be sure and make sure that what it delivers is that what the actors and stakeholders in your local context aim for, because otherwise it will end up in disappointment. And I believe that will not do good, but even perhaps harm to the implementation and scaling of integrated care. Eva, over to you. Sorry, I took a minute more, I'm afraid.
But I allowed you on because you were making really helpful remarks here, also really underlining what Verena was talking about, that there is just no blueprint and you need to have a consensus and a shared vision in a given territory or a municipality. And I also hope that somebody here listening in will ask you about what those different outcome measures are that we should be looking into. I would love to hear more from that, or maybe I will just ask you because I'm the moderator and can do so. Anyway, let's now move to our next speaker, which is Helmut. And I know that he did come online eventually. So Helmut, maybe you can switch on your camera. And we talked before, and I asked you, with all your experience in implementing these programs, what do you think, what for you was the main enabler that made implementing integrated care possible? So I hope that you can enlighten us, and look forward to your contribution, Helmut.
Good. We from Optimedis, with our about 40 professionals in healthcare, now have 25 years of experience in the conceptualization and practical implementation of integrated care. So the best known example may be Gesundes Kinzigtal, Healthy Kinzigtal, in the southwest of Germany. That has also been intensively evaluated, both in terms of working methods and relationships between partners, as well as health economics. Overall, however, we have developed, conceptualized, and set up many more projects. However, we also had to learn that for every project that was successfully launched, at least up to 10 projects got stuck. So, and that is the question of about now, what were the success factors for it? The problem is that we need a payer who is really interested in developing integrated care. And if there is a payer, either a hospital or some others, or the insurance company that is interested, or the municipality, or some legislator, then it is possible. It's not a problem of the people. And for us, maybe we should explain that integrated care stretches broader as only integrating two providers. It describes the entire continuum from improving the health literacy of the population, activating the population, promoting health, reducing the burden of disease for the regional population as a whole, but also optimizing care across the interfaces between the sectors, improving behavioral and pharmacotherapy, cooperation between all the professional groups in a better dialogue with patients as producers of their health, up to securing care in the current shortage of specialist staff and practice offices in Germany. So our key learning experience is these projects do not fail because of the people, neither the healthcare professionals, nor the citizens, the volunteers, local authorities. They always fail because of the cost bearers, the health insurance companies, if they are not really interested in developing this kind of care. And as long as the legislature does not incentivize health insurers to create real health and reduce disease burden, they will remain very narrow in their funding towards the respective sectors and not invest in the future of the respective population, especially if they are worried that this population might switch to another health insurer in short term. And that is the problem. We were really successful in different regions to produce a better situation for the population there. But this has to be provided with funding. And even in situations where we invested our own money and invested money from banks into from banking corporations into these activities, we need the refinancing afterwards, getting part of the results. So the shared savings approach Verena talked about. And in other countries, so we do work in Germany mainly, but as well in France. We had some projects in Belgium, in Netherlands, in Austria, in Switzerland, and in UK. In other countries, we always experience the same situation. The financing question is the real target that has to be tackled. And if you are not able to reorganize the incentive system of the healthcare system, then you will fail. You have some pilot projects, nice to look at, but they are not really scalable. They are not organized over 20, 40 years, and that is the problem. And you need the providers and the people to have a long-term project. These projects are failing if they are just only done for 2 or 3 or 4 years, like often in these innovation pilots that can be done. So that would be my first input.
Fantastic, Helmut. And it is really also reflecting indeed what Verena was saying, and also something we have seen ourselves, not just in your projects, but other projects as well. Projects that seemed to deliver, but were discontinued because the funding stream wasn't there and there was no way to, for taking it up or integrate it into the normal financing system. Well, it's as if this is all planned, and basically it is, because now we are going to hear from Søren, and he is going to talk about those incentives. And what are the different models? One that you actually apply, Helmut, shared savings, and how to do this, and what the barriers are, and what our options are. So, Søren, please enlighten us.
Yeah, thank you very much, and thank you for the opportunity to speak to you today, and also for this plug. It really aligned nicely with what I have to say. Because one of the core strategies that both the brief and Verena and also Helmut's talk now highlighted is how can we use financial incentives to ensure that the efforts across providers are well aligned. I believe this is really crucial, because if this is not in place, then you can have the best integrated care model. It may not deliver what it could have done if the incentives are not well in place. I want to show you just a single slide here that summarizes some work we did together with colleagues here at DaCHE and at the Steno Diabetes Center in Aarhus where we tried to review the literature on financial incentives that can be used to support integrated care. And I can really echo Mika's point also that the evidence base could be strengthened, not just when it comes to integrated care, but also when it comes to the financial incentives that can be used to support integrated care. Actually, I was surprised how little robust evidence we could find across these common types of payment models that are listed in the table you see. And of course, I cannot go into detail with all of this today, but I'd like to focus on the one that to me seems to be the most promising, namely the shared savings model that Helmut also mentioned. This involves that provider shares a proportion of the realized savings compared to expected costs, but it's conditional on meeting minimum quality and savings targets. I think this model is particularly exciting because it sets providers free to choose the activities they find the best for a particular group of patients or a particular patient even. And in that sense, it aligns well, it would also with your call for models that are patient-centered, because you can do this within this framework. You don't have to give everyone the same activity to be financially rewarded. Of course, the evidence base here is still developing, but still there are studies and very robust studies that have demonstrated maybe modest, but at least measurable results both on its ability to control costs and quality also after implementation. We have some evidence from the US and there's evidence from the Netherlands also that I think seems promising, and if you add to this ability to do something that is really tailored to the patient, I think this is an exciting way of paying. However, and I think this is really important, we found that there is one significant limitation of these shared savings models in their current form, and that is the lack of effective mechanisms for incentivizing long-term prevention. Because of course, if you're incentivized to save in the current period or in the near future, then what is the incentive to invest in the short run to get benefits in the future? And I think sometimes when we really want to prevent, for example, complications of diabetes patients, it could be the big ones such as amputations or kidney failures. It may be that some of the patients we want to reach require extra effort. And actually, if we look at the total cost, there might be a need for higher cost in the short run. And then, yes, I think the return of this investment will come, but it may not materialize until 5 or 10 years down the line. And to complicate matters even more, this investment could fall in other sectors than those that have to make the initial investment. And it could also be, as Helmut was saying, that patients are moving between providers. So from a provider perspective, investing in something that comes along down the line, a long way down the line, this could feel risky and uncertain. So I think this creates a fundamental misalignment of incentives. Why would you want to invest in something today when the benefits might go to someone else and might come much later down the line? I think this is a really important challenge to address, both from a research and a practical perspective. And I can say that we are trying to deal with this at the moment in a research practice project we're doing together with colleagues at the Estonia Diabetes Center in Aarhus. And we are working with the Danish health cluster and hoping to be able to test out a model that could potentially address this misalignment of incentives. It's still in its early phases, but if we are allowed, we would be very happy to come back and share results when we have them. And with this cliffhanger, I think I can end my presentation and then say that I'm really happy to take questions, of course, and discuss further with you how we can address this challenge in the future. Thank you.
Thank you very much, Søren, and thanks also for the cliffhanger, and also pointing us towards how to deal with this long-term prevention issue, which is, of course, a huge challenge. And I think it will be very interesting to hear from the others on this subject, especially also from Helmut. But before we do, and also start to let's see what happened in the chat box. So we'll ask now everybody to switch on their cameras, and especially now also you, Erica, and tell us what happened in the chat, and then we can start to deal with the questions one by one.
Okay, thank you very much. Yes, a lovely, lively chat box today. Hopefully we've got enough time for 2 rounds of questions. But to kick us off with, question on clinical governance. So how does clinical governance work with multidisciplinary teams? How do we ensure sort of like safety of care? A couple of questions about quality of care with multidisciplinary teams as well. So how do you assess the quality of care, and who is ultimately responsible for setting and meeting quality targets when you're specifically working in these multidisciplinary teams? A question that sort of I think Helmut touched upon in his presentation, but is probably of wider relevance. How do we navigate the disconnect between expectations that integrated care programs will result in beneficial outcomes long term, but often require short-term impact assessment to secure the longer-term funding? So how do we sort of like balance that disconnect? And one last one is, you mentioned there are new roles that you need. What are the, in your presentation, Verena, what are the health workforce implications of integrating care across disease groups, but also between health and social care? If you could summarize that in a couple of sentences, that would be great. Thank you very much. I'm going back into the chat now.
Yeah, so keep those questions coming. We can start actually with the multidisciplinary team questions on how to do clinical governance, how to set the targets. I hope Mieke, would you be able to provide an input there, and then the others can come in?
Yeah, well, when we're talking about in this in particular about people with multimorbidity, and it's clear that these people require all kinds of multidisciplinary care, but in particular also coordination is very important. Coordination is important within healthcare, because people they use primary care, they need certain types of hospital care, but also I believe that when we talk about the integration for people with multimorbidity, the connection and the collaboration with the social care sector is very important. And it depends. For a large part, it depends on what the type of care is that the person needs, what the care providers need to be involved. But there should be always self-management support. There should be always care coordination, and there should be always some navigation help for people. And that, of course, that depends also on the structure of the health system, to what extent people need professional help with these tasks. But it's clear that this requires a lot of changing in the curricula of the health workforce. I believe that at the moment there are several EU joint actions working on this, and there's also a policy brief planned on the implementations of integrated care models for the health workforce. So yeah, hopefully we can come back on that later. But yeah, maybe Verena, you want to add, because I think it's a very important topic for all of us.
Verena, would you like to add to this?
Sure. I think although Mika mentioned already almost all aspects which are relevant, but I think the question was also related a bit to move from the pilot stage into sustainability. And with respect to the organization here, it seems that financial sustainability again is of importance. So if there is a reform with respect, for example, to pooling budgets, this can again be reinvested in, for example, a team infrastructure or in new professional roles. And in some countries, it is already more institutionalized with the governance at, for example, at the workplace, at the system. We find this in the UK with integrated care systems, which more have formalized, structured in commissioning arrangements. And this is for sure supporting the sustainability, or also in terms of workforce. If you have temporary contracts, they for sure undermine long-term functioning. And sustainability needs permanent staffing here. So again, referring to everything needed for the clinical governance question. Yeah.
And maybe while we have you, there was also this question about, what are those new roles? Can you maybe single out a few that were particularly conducive for, establishing integrated care that you can think of?
I think it's not only the one new professional role which is needed, because this also depends on the project. So on many projects, of course, we have seen the new professional role of care coordinators, which are a very important link very often between the patient and the different care providers involved in terms of communicating, arranging appointments, so on and so on, keeping it more in a collaborative manner. But what was also very important is to create new structures in order to implement multidisciplinary teamwork. So for example, in the UK, we had one project where they implemented multidisciplinary health and social care groups, where they involved a very diverse group of professionals. For example, practice managers were there, practice nurses, GPs, but also social workers, district nurses, so a staff from the local authority. And this brought in a very a skill mix of professionals in each group according to their availability. And sometimes what they also did is to co-locate the staff where previously only one professional group was found. They co-located, for example, a social worker to the nurse, and to ensure a collaboration here. Or in other projects, they, for example, in Denmark, they created meetings during their, like once a week during their lunch break. They were exchanging about high need patients, where they should put a bit more focus on, and to make everybody aware of, for example, we have invested in this area, so maybe you can have a look here. And it was according to the availability, of course, but everybody really participated because they experienced the benefit of these reoccurring multidisciplinary lunchtime meetings. And
So it's really the roles, new roles in general, not necessarily depending on the context, but also creating, platforms for them to meet and coordinate their work together.
exactly.
The next question was really about, well, something that was flagged up very clearly by both Helmut and Søren, which was the question, this disconnect between achieving these short-term results but at the same time trying to get long-term funding. So I would like to start with Helmut here, because Helmut flagged it up that this was his main barrier, but he also succeeded in some cases, like for example at Kinzigtaal, with getting an insurer on board long-term. So I would like to hear from Helmut if he can share how he did that, and so not to focus on when it didn't work, but when it worked, and what his approach was in these cases. So Helmut.
Yeah, there are always some windows of opportunity. and you have to detect them and to use them strongly. That was the case in Kinzigtal, the window of opportunity that the main local insurer was very much interested in new innovative forms of cooperation in healthcare. And they were astonished that we promised them that we would work only out of the results we get. So that was the reason why we started there, and we started the same kind of intervention in other parts as well, with the idea that we only get money if we are successful in reducing the total cost of care for this population.
I get that, but what was your window? How many years did they give you? Because I'm assuming that they weren't expecting results after 1 year. So what was the window they were giving you?
No, that was the insurer, the AOK in Baden-Württemberg. They were clever. They expected the gains only after 3 to 4 to 5 years. They knew that it's difficult and complicated to arrange these kinds of gains. But we already were successful in the first 2 years. So we were better than their expectation. But you are right. At the moment, the insurers in Germany and in other countries are under big pressure. And this pressure forces them to think about 1 year results. And that's a problem for all of us who are doing integrated care. We know it needs a lot of investment a lot of investment in trusting people, in changing their ways of working, in changing the ways of thinking about health, actually. So to really take the clients into the process as producers of health. It's a totally different mindset that has to be developed, and that needs time.
So indeed, so clever payers is what we need. Clever payers. Let's go to
just one other possibility as well. Sometimes it's possible to have as well pharmaceutical companies as partners. It's not easy, and it's a lot of discussions. You have to be careful very strongly, but nevertheless, sometimes they want to have a medication being successful, to be able to run out with this medication. And they know this medication alone is not successful, but together with a digital app solution or with some development and change in the way of working for this specific problem, then that would be a successful tool. And so then you can connect. So you have a second partner inside a project, or you have companies like working just for the workers, for their own health. So that you can join efforts. We do it in one region with a big local enterprise that is interested that their workers and their families are healthy and not sick and have the problem that they have a lack of work.
So you need others, other stakeholders to be involved.
You need to have an open mind.
Can I go back to Erica for maybe one or perhaps two final questions, and one that I will definitely also ask Søren about. I know you have thoughts also about this issue, but I wanted to check with Erica if there's any.
Okay, so just one quick
Give
question.
Give me one.
So who benefits from integrated care? Are we talking about collective benefits, individual benefits? Are we talking about health outcomes? Are we talking about cost savings? Who benefits from integrated care?
That's a perfect question for Søren. Søren?
Well,
Please, right?
before I answer that, I would like to just say in terms of this challenge of demonstrating results in the short run, I think one thing we showed in a paper a while ago is to also maybe focus on the mechanisms that you are expecting to work, because many times we're guilty of looking at the outcomes, and in the short run we don't find an effect and it's discouraging. But actually, if you think that what is going to create the outcome is, for example, providers working more closely together, you could study that. That's the mechanism that needs to be in place. And if you can demonstrate that these mechanisms that are contributing to the outcomes in the longer run are actually already starting to improve, then that's one way of demonstrating
Very good point. Yeah.
activities in the short run. Who benefits?
Minutes.
I don't know if I can answer that. I think in the ideal world, there has been a promise of these models sometimes to both demonstrate outcomes, improvements for everyone, and cost savings. I think it's really rare we find this, especially when we study the multimorbid. Sometimes it may not be a realistic expectation. I think this was also one of Mika's points, to have realistic expectations. But I think for the payers, hopefully they have the patient's health in mind. And I think if this is not one of the objectives, then why are we actually doing it?
Thank you. So what we always do, we go back to the keynote speaker, Verena in this case, for your final thoughts before I wrap it up. So Verena, what have you learned today, or was it all in line with what you've studied? What is the main takeaway for you?
It's interesting if we discuss integrated care, and if I look at the chat, that some questions are really reoccurring, and there seems to be a need to on the one hand to discuss them for sure a bit further, but also to explain some mechanisms behind, and that challenges are reoccurring with respect to financing or funding integrated care, because we get stuck here with the structures we have, which are sometimes really difficult to change and to adapt in order to achieve the care outcomes we want to achieve. And what we have stressed again were the issues of trust and how to start such a collaboration, and that this is really something inevitable in order to be successful, but this is nothing you can guarantee from the beginning on which needs to develop. I think this really shows how individual and context-specific integrated care always needs to be, and that, recalling some of the comments, that you need to adapt your solutions to your context again here, and can find some insights and use some of them, but maybe not all.
I like how you ended with the notion also of the importance of trust, which has become a huge, I think, international issue, the losing trust we have. And if you build a good integrated care system, will help rebuild trust. And that's something that is so important, I think, also for our health systems, for our democracies, to be honest. So now I'll be closing. Thank you so much. First, foremost, to all the speakers today for their contributions, also to you for joining. And please also join us again next week, Tuesday. There will be a webinar, which is about breaking barriers, fostering collaboration to strengthen cancer prevention and care. So also a very interesting subject. Please tune in, and thank you very much for joining us today.